फैजान,
हेलो।
यार
जी
गलत
सर।
गलत की डाली है कि लाइव नहीं है अभी?
नहीं, होगी क्लास,
ओके,
देखिए
लाइव हो
अभी
गई है
वो
क्लास, ठीक है
कभी
ठीक
कभी यूट्यूब पे थोड़ा सा टाइम ले लेता है सर।
ओके
जी सर।
ठीक है। सो आई थिंक वी आर लाइव। ओके, सो विल स्टार्ट टुडेज क्लास। जस्ट गिव मी अ क्विक confirmation that you can hear me and you can see my screen. ओके, ठीक है। तो हाय प्रकाश, हाय, हाउ आर यू? ठीक है, विल टॉक इन हिंदी, विल ट्राई इंग्लिश, ओके, बिकॉज this will be live on YouTube and a lot of students will be watching it even after today's class. Okay, so I'll try कि मैं हिंदी इंग्लिश दोनों में बात करूँ, right? I've tried to keep this class very very basic. So at the outset, let me just clear one thing, that this class is from MBBS point of view, ठीक है? जब it's not from a PG entrance point of view, तो MCQ oriented class नहीं होने वाली है. It will be more of conceptual learning, वाइवा क्वेश्चंस, स्पॉटर्स, क्योंकि रेडियोलॉजी में लॉन्ग क्वेश्चंस, शॉर्ट क्वेश्चंस नहीं आते हैं, प्रॉफ में, थ्योरी में नहीं आते हैं. मोस्टली क्लिनिकल क्वेश्चंस में रेडियोलॉजी इंटीग्रेटेड होती है, जो कि आप क्लिनिकल फर्रे सीरीज में कवर करोगे. हम बात करेंगे वाइवा में, अगर कोई आपको चेस्ट एक्सरे दे दे, जो कि दिया जाता है, तो उसको कैसे आपको बोलना है एग्जामिनर को. सिमिलरली ऑर्थोपेडिक्स में बोन एक्सरे का वाइवा होता है, उसमें कैसे बोलना है एक्सरे रिपोर्टिंग. एंड सब इंपॉर्टेंट रेडियोलॉजी स्पॉटर्स जो कि मेडिसिन के या पीडियाट्रिक्स के स्पॉटर्स में आते हैं. ठीक है, तो गुड इवनिंग, गुड इवनिंग एस के अननोन, हाय. So just a quick request that please tell me your names also in the chat, so that I can communicate with you. I want it to be a two-way communication and not a one-way communication with you, right? So without further ado, let's just start with today's class. Now, टॉपिक्स that हम आज जो इस क्लास में कवर करेंगे, टॉपिक्स हैं: हाउ टू रीड अ चेस्ट एक्सरे, इंपॉर्टेंट चेस्ट एक्सरे पैथोलॉजीज, हाउ टू रीड अ बोन ट्यूमर. सो बोन ट्यूमर का एक रेडियोलॉजिकल अप्रोच क्या है, आपको कैसे बोलना है एग्जामिनर को, एंड सम मिसलेनियस स्पॉटर्स, राइट? ए टू जेड रेडियोलॉजी नहीं कवर हो रही है, अगेन आई एम टेलिंग यू, इट्स नॉट एन एमसीक्यू ओरिएंटेड क्लास, इट इज मोर ऑफ अ प्रॉफ एंड वाइवा ओरिएंटेड सेशन फॉर ऑल ऑफ यू. नाउ, normal chest x-ray, how do we acquire it? So first of all, a normal chest x-ray view is a PA view, erect. Okay, so first of all, it is acquired in the erect position, as you can see here in this image. It is a PA view. PA stands for posterior anterior view. Posterior anterior view, right? मतलब क्या है कि रेज आएंगी, दिस इज माय एक्सरे ट्यूब and this here is my detector, right? So rays are coming from the x-ray tube towards the back of the patient and the detector is in front. So PA view, posterior anterior view, first of all. Now कितना distance होता है between the chest x-ray and the detector? This is known as the film focus distance. This is nothing but distance between x-ray tube and detector. तो चेस्ट एक्सरे में ये डिफरेंस होता है 6 फीट और 180 सेंटीमीटर्स. 6 फीट याद रखेंगे हम, राइट? नॉर्मल एक्सरे जैसे आपका एक्सट्रीमिटी एक्सरे हो गया, जिसमें आप टेबल पे लेट जाते हो, ऊपर से एक्सरेज आते हैं, नीचे डिटेक्टर होता है. या एब्डोमेन एक्सरे हो गया, जिसमें अगर आप लेट जाते हो या खड़े होकर भी एब्डोमेन एक्सरे जो होते हैं, वो सारे 100 सेंटीमीटर पर होते हैं. बट चेस्ट एक्सरे एक इंपॉर्टेंट एक्सरे है जिसमें हम सब कुछ 6 फीट पर करते हैं. ना कौन से फेज ऑफ रेस्पिरेशन में होता है एक्सरे? वी डू इट इन अ फुल इंस्पिरेशन एंड आर्म्स रोटेटेड एंटीरियरली. सो आप जैसे देख रहे हो कि ऐसे बकी पकड़ रखी है पेशेंट ने, पीछे से एक्सरेज आ रहे हैं, आगे डिटेक्टर है, हम ऐसे पकड़ रहे रखी होती है बकी. पेशेंट ने भी, देखो, पेशेंट ने भी आगे एंटीरियरली हाथ से बकी पकड़ रखी है, ताकि स्कैपुला हट जाए, ताकि स्कैपुला हट जाए. एंड कन्वेंशनल एक्सरे चेस्ट इज पीए व्यू चेस्ट. ठीक है. नाउ, पीए वर्सेस एपी का डिफरेंस जानना बड़ा जरूरी है हमारे लिए. एग्जामिनर पूछता है एग्जाम में कि फर्स्ट टेल मी व्हाट व्यू इज दिस, इज इट अ पीए व्यू और इज इट एन एपी व्यू. तो कैसे डिफरेंशिएट करेंगे? पीए व्यू में इफ यू कैन सी दैट द क्लैविकल्स आर outwardly rotated. These are the medial end of the clavicles. They are outwardly rotated. They are not overlapping the lungs. And why is it? Because the patient has hold the bucky like this. So scapula laterally इसके flare up हो जाते हैं. एंड हम इसलिए कराते हैं ताकि ओवरलैप ना रहे बोन्स का लंग से, एंड हमें एक क्लियर व्यू मिले, हमें एक क्लियर लंग फील्ड्स मिले. दैट इज द रीजन वी डू अ पीए व्यू विद आर्म्स रोटेटेड आउटवर्ड्स. ठीक है, तो पहला डिफरेंस हो गया पीए वर्सेस एपी में क्लैविकल का. तो पीए व्यू में क्लैविकल्स आर आउटवर्ड्स, जबकि एपी व्यू हम ऐसे सीधे करके लेते हैं. आगे से एक्सरेज आ रहे हैं, पीछे डिटेक्टर है, हाथ सामने है. तो देखो एपी व्यू में हमारा क्लैविकल कहाँ है, ये हमारा मीडियल एंड ऑफ क्लैविकल है, सॉरी स्कैपुला. दिस इज माय मीडियल स्कैपुला. क्लैविकल की बात कर रहे हैं हम, सॉरी स्कैपुला है सब. स्कैपुला पीए में आउटवर्डली रोटेटेड है. दिस इज स्कैपुला आउटवर्ड रोटेटेड in PA, whereas in AP the scapula is medial. तो PA में outwards है, AP में inwards है. ठीक है. और सेकेंड डिफरेंस जो मीडियल एंड ऑफ क्लैविकल है, देखो आप पीए व्यू में जो क्लैविकल का मीडियल एंड है, ये है हमारा मीडियल एंड ऑफ क्लैविकल. ठीक है, ये है हमारा मीडियल एंड ऑफ क्लैविकल. दिस इज बिलो द एपेक्स ऑफ लंग. ये वाला जो पार्ट होता है हमारा, दिस इज माय लंग एपेक्स. तो इन अ पीए व्यू, क्योंकि हमने आगे कर रखा है अपना हाथ, क्लैविकल का मीडियल एंड नीचे हो जाता है थोड़ा. तो इन अ पीए व्यू मीडियल एंड ऑफ क्लैविकल बिलो लंग एपेक्स. जबकि आप एपी व्यू में देखो कि क्लैविकल बिल्कुल टॉप पर है, यहाँ पर क्लैविकल बिल्कुल टॉप ऑफ लंग एपेक्स पे है. सो इन अ एपी व्यू the medial end of clavicle is at the lung apex. ठीक है. एंड तीसरा इंपॉर्टेंट पॉइंट है हार्ट साइज. हार्ट साइज इन अ पीए व्यू इज नॉर्मल. तो अगर हम कार्डियोमेगली कार्डियोमेगली कमेंट करेंगे तो कौन से व्यू पे करेंगे, हम पीए व्यू पे कार्डियोमेगली कमेंट करते हैं. अब एपी व्यू की दिक्कत क्या है कि एपी व्यू में रेज आगे से आ रही हैं बट डिटेक्टर पीछे है. ठीक है. तो एपी व्यू में क्या है, अगर ये पेशेंट का चेस्ट है, लैटरल बता रहा हूं मैं, ये आगे उसका हार्ट हुआ, पीछे डिटेक्टर है, एंड रेस हमारी आ रही हैं आगे से. ठीक है. तो एपी व्यू में आपकी जो हार्ट की शैडो बनती है वो थोड़ी रिलेटिवली enlarged बनती है than actual heart size. So in an AP view, that's why we say there is a relative cardiomegaly. ठीक है, रिलेटिव कार्डियोमेगली होती है क्योंकि डिटेक्टर से दूर है हमारा हार्ट, थोड़ा मैग्नीफाई हो जाता है. तो अगर हमें कार्डियोमेगली कमेंट करना है, इफ यू वांट टू कमेंट ऑन कार्डियोमेगली, टेल मी विच एक्सरे व्यू विल बी look into. Will always and always comment on cardiomegaly on a PA X-ray view, not on an AP X-ray view. ठीक है. तो पहली बात हमने क्या देख लिया, AP वर्सेस PA. नाउ अब मान लो एग्जाम में ये एक्सरे आता है, तो हाउ डू यू फर्स्ट से दिस, आप कैसे बोलना स्टार्ट करते हो, हाउ डू यू डिस्क्राइब अ चेस्ट एक्सरे. तो इसको हम थोड़ा मैग्नीफाई करके यहाँ पे ले आते हैं. ठीक है. तो आई एम श्योर ऑल ऑफ यू कैन सी दिस. ठीक है. तो फर्स्ट ऑफ ऑल यू tell whether it is the which part of x-ray is this. So first of all, this is how you say a chest x-ray. So this is a chest x-ray of Mr. Dash, who is a 57-year-old male. So number one comes patient details. So chest x-ray of, let's say, Mr. Vikas, a 57-year-old male. This is a PA view of the chest. sorry, this is a PA view of the chest. And uh, in this, first of all, I'll tell about the rotation. I'll tell about the quality of film. उससे भी पहले क्या बताऊंगा मैं? उस सबसे पहले मैं बताऊंगा patient details. Then I'll tell about quality of film, and then I'll go on to lung findings. क्वालिटी ऑफ फिल्म में क्या क्या आता है? क्वालिटी ऑफ फिल्म में नंबर 1 आता है हमारा रोटेशन, फिर दूसरा आता है हमारा एक्सपोजर। ठीक है, तो रोटेशन कैसे देखते हैं हम? नंबर 1 आता है हमारा रोटेशन। तो रोटेशन हम देखते हैं कि जो हमारा मिडलाइन है, मिडलाइन मतलब स्पाइनस प्रोसेस, midline as described by spinous process, इसका हम डिस्टेंस देखते हैं विद द मीडियल एंड ऑफ क्लैविकल्स। तो दिस डिस्टेंस, so this should be equidistant. If the medial end of clavicles is एक साइड पे ज्यादा डिस्टेंस है, दूसरी साइड पे कम डिस्टेंस है, then we say that this film is rotated. So first of all, we'll in this case we'll say that there is mild rotation of the film because the left side clavicular distance from the spinous process is a little more as compared to the right hand side. So mild rotation है यहाँ पे. Okay, Abukar, I'll tell everything in English. You're right, because most of the students who will be watching it will be from all over India. So let me just say it in English. So first of all, when we describe the quality of a film, we talk about rotation of the X-ray, rotation of the film. Rotation of film हम कैसे देखेंगे? We see the distance from the medial end of clavicle with the midline. Midline कैसे described है हमारी? Spinous processes से, spinous process. Second, we'll talk about exposure. Now, exposure के लिए we say that the vertebra, देखो ये vertebra की outline है. This should be just visible behind the hard shadow. Okay, in this case you see that the vertebral bodies are just visible. You can outline the vertebral bodies. देखो, this is the vertebral body. Similarly, this is a vertebral body. You can just outline this. So this is adequate exposed. This film is adequate exposed. Now, exposure was usually a term जब हम डिजिटल एक्सरेज नहीं करते थे, जब हम कन्वेंशनल एक्सरेज करते थे तब एक्सपोजर किया जाता था फिल्म को. बट सिंस नाउ इट इज डिजिटली एक्वायर्ड एट ऑलमोस्ट ऑल प्लेसेस, सो एक्सपोजर इज नॉट रियली द टर्म दैट वी आर लुकिंग एट. मेनली इट इज रोटेशन ऑफ द फिल्म दैट इज इंपॉर्टेंट. तो हमने कैसे बोला? दिस इज अ चेस्ट एक्सरे ऑफ अ 36-year-old मेल, मिस्टर विकास. एंड उसके बाद हम क्वालिटी आए, क्वालिटी ऑफ एक्सरे पे आए. द फिल्म इज माइल्डली रोटेटेड एंड द एक्सपोजर इज एडिक्वेट. ओके, सो दिस इज पहला पार्ट हो गया. नाउ विल गो फ्रॉम सेंटर टू द पेरिफेरी. Now we'll go from center to the periphery. We'll first describe the airways. तो airways में हम ट्रेकिया के बारे में बात करेंगे. The trachea is in midline. ट्रेकिया में क्या बताना है? Midline है कि off midline. So the trachea is in midline. Then we'll go to the cardiovascular structures. The cardiac silhouette or the cardiac outline is normal in size and position. So we'll say that the cardiac silhouette, this is the cardiac silhouette that I'm drawing for all of you. The cardiac silhouette is in normal position and is of normal size. Then we'll go on to the hilum, the bilateral hyla. See, this is one hyla and this is another hyla. The bilateral hyla are normal in size and position. Then we'll go on to the diaphragm, bilateral costophrenic angles. This is my costophrenic angle. Bilateral costophrenic angles are sharp. And finally, I'll talk about lungs. So, bilateral lung fields show normal bronchovascular markings. And finally, we'll talk about bones and soft tissue. We'll talk about bones and soft tissue. So I'll write it down. What is the normal line that you have to say? So this is, so in the same X-ray, I am, copying this image and I'll paste it in. Uh, I'll add another page. Wait. So how do I describe this X-ray? This is a chest X-ray PA view of a 36-year male. There is mild rotation of the patient. Exposure is adequate. Exposure is adequate. देन हम बात करेंगे एयरवेज के बारे में. तो ट्रेकिया इज मिडलाइन. कार्डियक सिलहाउट. सिलहाउट का मतलब होता है शैडो. कार्डियक सिलहाउट इज नॉर्मल इन साइज एंड पोजिशन. बायलेटरल सीपी एंगल्स आर शार्प. ठीक है, अगर शार्प नहीं होंगे तो क्या टर्म यूज करेंगे? वर्सेस ब्लंटेड. तब हम ब्लंटेड यूज करेंगे. ठीक है. देन विल टॉक अबाउट लंग फील्ड्स. बायलेटरल लंग फील्ड्स जो नॉर्मल ब्रोंको वैस्कुलर markings, right? And finally we'll comment on bones and soft tissue. Bones and soft tissues are normal. Bones and soft tissues are normal. So this is how you say it in your profs, in your viva about a chest X-ray. ठीक है, सब लोगों को ये terminology याद होनी चाहिए. This is the sequence of structures that you see, and this is the sequence in which you delineate and mention each structure. So दोबारा recap में बता रहा हूँ, थोड़ा time लगेगा इसमें, but this is very very important for us for the rest of the class. तो firstly हम देखेंगे, मैं एक बार erase कर देता हूँ. ठीक है, तो पहले हमने देखा ट्रेकिया. ये देखो, ये वाली शैडो दिख रही है आपको ट्रेकिया की. दिस ब्लैक स्ट्रक्चर, these are the outlines of the trachea. The trachea is in midline, right? Then we'll comment on the cardiac silhouette. The cardiac border, the cardiac silhouette is normal in size and position. Then we'll comment on bilateral CP angles. Bilateral CP angles are normal. Then we'll comment on hyla. Bilateral hyla are normal in size and size and shape and position. Then we'll comment on lung fields. Bilateral lung fields show normal bronchovascular markings. And finally, bilateral soft tissues and bones are normal. ठीक है, bilateral soft tissue and bones are normal. एक चीज इसमें रह गई मेरे लिखनी, वो भी लिख लेते हैं. CP angles are sharp. इसके आगे लिखना है bilateral hyla are normal in size and position. ठीक है, सो ट्रेकिया, हार्ट, सीपी एंगल्स, हाइला, लंग फील्ड्स एंड बोन्स एंड सॉफ्ट टिश्यू. दिस इज हाउ यू रिपोर्ट अ चेस्ट एक्सरे, राइट? नाउ पीए वर्सेस एपी वी हैव ऑलरेडी कवर्ड. सो लेट्स जस्ट सी द एयरवेज. एक स्टूडेंट का क्वेश्चन आया था दैट हाउ टू आइडेंटिफाई ट्रेकिया. ठीक है, तो एयरवेज में व्हाट ऑल एयरवेज कैन वी सी ऑन अ चेस्ट एक्सरे? स्टार्टिंग फ्रॉम ट्रेकिया, this structure here, this is the trachea, right? Now if you see carefully, you can see that the trachea is dividing at this point. Okay, दिख रहा है आपको क्लियरली? ट्रेकिया यहाँ पे डिवाइड हो रहा है दो में, इनटू अ राइट एंड इनटू अ लेफ्ट ब्रोंकस। तो अगर मैं ऊपर से आउटलाइन बनाऊं, दिस इज द आउटलाइन दैट इज गोइंग, एक यहाँ पे डिवीजन निकल गया, एक यहाँ पे निकला नीचे, right? And on the left hand side you can see this is the left main bronchus. So this was trachea. The point at which it divides, it is known as carina. This is carina. The trachea divides at the level of carina into the left main bronchus and the, sorry, the right, really right hai na, sorry, into the right main bronchus and the लेफ्ट मेन ब्रोंकस। ओके, लेफ्ट राइट किसी को नहीं गलती करनी है, ये लेफ्ट साइड है, ये वाली राइट साइड है। ओके, नो बट नो वन शुड मेक दिस मिस्टेक, राइट वर्सेस लेफ्ट, राइट? So the trachea divides into the right main bronchus and the left main bronchus. Now note that the left main bronchus has a slight horizontal course, right? It is slightly horizontal as compared to the right hand side. Right hand side has a more vertical course. Right main stem bronchus has more vertical course. Therefore, if you swallow accidentally any structure or any food particle, let's say you swallow any food particles, in which bronchus is it more likely to go, the left or the right? Tell me in the chat box. Which side aspiration of a food particle is more common, right or left? Abukar, tell me. ओके, इसमें से हॉरिजॉन्टल कौन सा है और वर्टिकल कौन सा है? राइट, राइट, यस। Since right main bronchus has a more vertical course, it will be more in line, right? It will be more in line with the trachea, है ना? So aspiration pneumonia, therefore aspiration pneumonia is more common on the right as compared to the left side of the lung. Okay, this is directly related to the anatomy. Yes, you're right, because the right mainstem bronchus is more vertical as compared to the left mainstem bronchus, which is more horizontal. Now, the right mainstem bronchus further divides into the lobar bronchus. So this will be my right upper lobe bronchus, and this bigger bronchus, this is known as my bronchus intermedius. Bronchus intermedius. Okay, so these bronchi are well seen on a chest X-ray. On a chest X-ray आपको सब दिखेगा, ट्रेकिया भी दिखेगा, लेफ्ट मेन, राइट मेन, राइट अपर लोब एंड ब्रोंकस इंटरमीडियस, राइट? ब्रोंकस इंटरमीडियस कौन कौन से लंग के लोब्स को सप्लाई करता है? द राइट मिडिल लोब एंड द राइट लोअर लोब, इनके ब्रोंकस इस ब्रोंकस इंटरमीडियस से ही निकलते हैं, राइट? So this is the airway anatomy that we can very well appreciate on the chest X-ray. देखो इस वाले, in this X-ray also you can see that this is the trachea. This is the trachea which is dividing at this level into a right and the left mainstem bronchus. So this will always be seen on a good quality chest X-ray, and hence you should comment on the airways first when you're reporting a chest X-ray. Now after airways, within the airway there is a very important line which is known as the right paratracheal stripe. As the name suggests, right paratracheal meaning the line formed with the right wall of the trachea and the lung. तो एक साइड इसके लंग होगा, लंग का कौन सा पार्ट? राइट अपर लोब, और एक साइड हो गया ट्रेकिया। तो ट्रेकिया की वॉल जो होती है, इट अबट्स द राइट अपर लोब एंड इट फॉर्म्स अ लाइन। देखो, दिस इज माय राइट paratracheal stripe. It is such a thin line, is a very thin line. This is the right paratracheal stripe. Now, in some situations, your right paratracheal stripe will be thickened. So if there is anything between the trachea and the mediastinal pleura on one side, this will get thickened. So as you can see, this is the trachea, this is the right upper lobe. इन दोनों के बीच का distance is increased. This we say that the right paratracheal stripe is thickened. All right. Now in this case, you can see that there were bulky lymph nodes. There were lymph nodes. कौन सी lymph nodes? Paratracheal lymph nodes. Right paratracheal lymph nodes, which were causing thickening of the paratracheal stripe. Now this helps us in understanding that there might be mediastinal lymphadenopathy. lymphadenopathy. ठीक है, so thickening of right paratracheal stripe can suggest a mediastinal lymphadenopathy, and one of the causes is sarcoidosis. Another important cause that you have to remember is tuberculosis. All right, so this is the basis of mediastinal lymphadenopathy on chest x-ray. Now another thing that you can see here is that in the previous x-ray the hyla was very small. आपको छोटा सा hyla दिख रहा था, मे बी हाइलर वेसल्स जाती हुई दिख रही थी, एंड इट वाज वेरी स्मूथ. बट इस केस में आप देखो, hyla is so bulky. hyla is bulky and lumpy also. ये बड़ा सा hyla हो रखा है हमारा. So this also suggests that in addition to right paratracheal lymphadenopathy, this patient has bilateral hilar lymphadenopathy. bilateral hilar lymphadenopathy. Right? So a lot of information you can guess from the chest X-ray only. Now, अगर हमें इस chest X-ray को रिपोर्ट करना होगा एग्जाम में, तो हम कैसे रिपोर्ट करेंगे? तो दिस इज अ PA व्यू ऑफ द चेस्ट. PA व्यू क्यों? क्योंकि हमारी स्कैपुला का मिडिल बॉर्डर बाहर की तरफ निकला हुआ है. राइट, स्कैपुला का मिडिल बॉर्डर बाहर है. सो दिस इज अ PA व्यू ऑफ लेट्स से 50-year-old मेल. द medial end of clavicles देखेंगे हम. ये middle end of clavicles हैं, एंड स्पाइनस प्रोसेस से ऑलमोस्ट इक्विडिस्टेंट हैं. दे आर इक्विडिस्टेंट फ्रॉम द स्पाइनस प्रोसेस. So we'll say that this is the chest X-ray of a 56-year-old male. PA view chest X-ray. The film is, the patient is not rotated. The exposure is adequate. Why the exposure is adequate? Because I can appreciate the vertebral body behind the heart. So this is adequate exposure, non-rotated film. Airways are in midline. Cardiac size and position is normal. Bilateral CP angles are sharp. Now hyla के बारे में अगर हम बोलना होगा, तो bilateral hyla are bulky. Bilateral hyla are bulky along with thickening of the right paratracheal stripe. Right. उसके अलावा अगर हमें बोलना होगा लंग्स में, bilateral lung field, तो normal bronchovascular markings, the bones and the soft tissues are normal. ठीक है, the bones and the soft tissues are normal. This is how you report a chest X-ray. Again, I am telling you because it is important from prof point of view. This is a PA view chest X-ray of this 56-year-old male. It is a non-rotated film with adequate exposure. The trachea is in midline. Cardiac size and position is normal. Bilateral CP angles are sharp. Bilateral hyla are bulky and increased in size. The right paratracheal stripe is thickened, suggestive of mediastinal and bilateral hilar lymphadenopathy. Bilateral lung fields show normal bronchovascular markings. Bones and soft tissues are normal. Right? This is how you report a chest X-ray. Now let's see various parts of the mediastinum, various parts of the heart, which forms the cardiac outline on the chest X-ray. So on the right hand side, we have an impression of the IVC, right atrium, and IVC, sorry, SVC, right atrium and IVC. Now, sometimes you might see an ascending aorta impression also, but it is only sometimes, right? So if you are asked about right heart border, right heart border, structures forming the right heart border, ये क्वेश्चन पूछते हैं स्ट्रक्चर्स फॉर्मिंग राइट हार्ट बॉर्डर। तो पहला आता है हमारा एसवीसी, सेकेंड इज राइट एट्रियम, and then third is IVC. These are the structures forming the right heart border. Learn them by heart. Structures forming the right heart border: SVC, right atrium, and IVC. Now remember, right ventricle, right ventricle does not form the right heart border. Right ventricle does not form the right heart border. ठीक है? Only right atrium form. Now लेफ्ट हैंड साइड पे क्या क्या बनाता है हार्ट बॉर्डर? तो सबसे ऊपर आएगा हमारा एओर्टिक आर्च, देन वी हैव मेन पल्मनरी आर्टरी, लेफ्ट atrial appendage, L appendage is left atrial appendage, and then the left ventricle. So if I were to write structures forming left heart border, इनमें आएगा हमारा aortic arch, main pulmonary artery, left atrial appendage, and left ventricle, and left ventricle. राइट, दिस हैज टू बी क्लियर। ठीक है, इसमें कोई आपको कंफ्यूजन नहीं करनी। तो इफ आई वर टू राइट, आई कैन से दैट राइट वेंट्रिकल एंड लेफ्ट एट्रियम, ठीक है, लेफ्ट एट्रियल अपेंडेज अलग बात है, राइट वेंट्रिकल एंड लेफ्ट एट्रियम डू नॉट फॉर्म हार्ट बॉर्डर ऑन चेस्ट एक्सरे PA view, chest x-ray PA view. So why ascending aorta is not forming the right heart border as seen in the image? Because इस image जहाँ से मैंने ली है, this was showing ascending aorta enlargement, so that's why is in this case ascending aorta is forming the right heart border, but normally it is not forming. It is somewhat ascending aorta का impression इधर की तरफ होता है, इधर से आती है हमारी ascending aorta। ठीक है, so ये हमारी ascending aorta यहाँ से निकलती है, this is my aortic wall, this hole is my left ventricle like this. इस केस में ascending aorta was dilated and in this case it was forming the right heart border, but normally just remember right heart border is formed by the right atrium, SVC and the IVC. Alright. Now see in right atrial enlargement, so जब भी right atrial enlargement होगा, since right atrium was forming the right heart border, the right heart border will bulge out like this. In a right atrial enlargement, you see the right heart border bulging out, and second important thing, height of the right ventricle is also increased. So right atrial enlargement का sign on chest x-ray, height and width of right atrial impression is increased on chest x-ray. All right. Now, in comparison, where is the left atrium located? So, left atrium, as I told you, does not form any part of the heart border and chest X-ray. Only a small part, left atrial appendage, forms the left heart border का छोटू सा part. So, where is it actually present on a chest X-ray? So, left atrium is somewhere like this. This is my left atrium. So left atrium is the posterior chamber of the heart. Okay, left atrium is the posterior chamber. So remember, left atrium is a posterior chamber of heart, and it forms the base of heart. The base of heart is formed by the left atrium. Remember that inferior part, this is not the base of the heart. This part is known as the inferior surface of heart. And inferior surface कौन बनाता है हमारा? This is formed by the right ventricle. तो राइट वेंट्रिकल इंफीरियर सरफेस बनाता है, लेफ्ट वेंट्रिकल लेफ्ट हार्ट बॉर्डर बनाता है, लेफ्ट एट्रियम पोस्टीरियर पार्ट ऑफ हार्ट बनाता है, एंड राइट एट्रियम राइट हार्ट बॉर्डर बनाता है. ठीक है, तो दिस थिंग यू कैन नॉट mess up. So if you are asked which chamber of the heart forms the base of heart, remember that this inferior is not the base. This is the inferior surface. base पीछे होता है. ठीक है, so कभी भी आपको base of heart में हमेशा लेफ्ट एट्रियम बोलना है, इंफीरियर सरफेस में आपको बोलना है राइट वेंट्रिकल. राइट वेंट्रिकल. ठीक है, तभी जब राइट वेंट्रिकल का एमआई होता है, राइट वेंट्रिकल वॉल एमआई होता है, तब हम क्या बोलते हैं उसको? इंफीरियर वॉल एमआई बोलते हैं. ठीक है, रिमेंबर इट फ्रॉम मेडिसिन कोरिलेशन. इंफीरियर वॉल ऑफ एमआई में कौन सा चेंबर इन्वॉल्व होता है? राइट वेंट्रिकल. ठीक है, तो इंफीरियर पार्ट इज फॉर्म बाय द राइट वेंट्रिकल. What are the signs of left atrial enlargement? Now, if you again look at this chest X-ray, सॉरी थोड़ी खिचड़ी पक गई है इसमें. ठीक है, now if you look at this chest X-ray, all of these structures lie in a line. All of these structures lie in a line like this. ठीक है, in a left atrial enlargement, what part of the heart enlarges? The left atrium. Now left atrium is the base of the heart, posterior part of the heart. तो वो तो हमें चेस्ट एक्सरे पे दिखेगा नहीं. उसका कौन सा पार्ट दिख जाएगा? लेफ्ट ऑरिकल दिख जाएगा. तो यू विल सी दैट there is bulging of the left heart border like this. Number one. Number two, widening of the carina. The carinal angle widens up because the left atrium pushes the carina wide. And number three, that you can see another density just behind the राइट हार्ट बॉर्डर. ये राइट हार्ट बॉर्डर था हमारा जो कि राइट एट्रियम बना रहा था. इसके जस्ट अंदर एक और डेंसिटी मिलती है. दिस इज द डेंसिटी ऑफ द लेफ्ट एट्रियम. तो दिस साइन इज नोन एज डबल डेंसिटी साइन. डबल डेंसिटी साइन. This is widening of carina, and this is straightening of left heart border. Straightening of left heart border. So what are the signs of left atrial enlargement on a chest X-ray? Number one is double density sign. Number two is widening of carina. And number three is straightening of left heart border. Okay, clear till now? I hope that you guys are understanding what I'm telling you. Give me some feedback in the chat box. How do you want me to conduct it? Are you guys understanding what I'm telling you? Okay. So this was right atrial enlargement and left atrial enlargement. So we've discussed airways. We've discussed airways. We've discussed the right paratracheal stripe. We've discussed the heart border. So what part of the heart border was this? This was aortic arch. Okay. Main pulmonary artery, the left atrial appendage and the left ventricle, then the SVC, right ventricle, right atrium, and the IVC, right? This part we have discussed. Now we'll talk about pulmonary arteries and we'll talk about hyla. So earlier there was a question that which part forms the hyla of the lung. So the main part of the hyla are the vessels, and which vessels? The pulmonary arteries and the pulmonary veins. So as you can see it on a corresponding CT correlate, this is the part of the lung hyla, and यहाँ पर what are the structures present? Mainly the vessels, pulmonary artery and pulmonary veins. What is more prominent here? The pulmonary arteries. So this descending branch, this vessel that you can see going down, finger-like projection, this finger-like projection, right? Finger-like projection दिख रहा है? So this is my right descending pulmonary artery. Right descending pulmonary artery. And on the left hand side, this is how it goes. थोड़ा posteriorly जाती है left hand side पे ना. So again, this is the left descending pulmonary artery. Right now, if I were to tell their exact position or origin कैसे करती हैं pulmonary arteries. So on the right hand side, around ये होगा, and on the left hand side around ये position होगी. Okay, so this descending pulmonary artery is almost always seen. So if you are wondering on most chest x-rays that what is this structure, is this an abnormal lymph node? No, this is the normal right descending pulmonary artery, right? And what is its normal size? Its normal size width of this is less than 15 mm. ठीक है, the width is less than 15 mm. So this is my pulmonary hyla, pulmonary hilum, which is formed by the pulmonary arteries and veins. Okay, so I'm erasing this thing so that you can again see that how does the pulmonary hyla look. It is very smooth. Normal hyla, if I talk about normal hilum, okay, normal hilum number one is very smooth outline, and number two, left is higher than right. Okay, what does left is higher than right means? That your left pulmonary artery, the left pulmonary artery is at a higher position as compared to your right pulmonary artery. Okay, normally the left hyla is slightly higher than the right hyla. This is the normal position. कितना difference होता है ये? Around 2 centimeters. This difference is around 2 centimeters. The left is higher than the right. Now, in a situation where the left is, if the right hyla is equal in height to the left hyla, मतलब यहाँ पर अगर आ गया हमारा हाइलम, ठीक है, मतलब क्या है इसका कि ऊपर से कोई लीजन होगा जो इसको पुल कर रहा होगा. That is why in case of a lung collapse, lung fibrosis, you will see that the right hyla is pulled up or the right and the left hyla are at equal heights. Similarly, अगर कोई लेफ्ट लोअर लोब का फाइब्रोसिस होगा, लेफ्ट लोअर लोब कोलैप्स होगा, तो लेफ्ट हाइला नीचे पुल डाउन हो जाएगा. अगेन बोथ द लेफ्ट एंड द राइट हाइला विल बी एट द सेम लेवल. So this is abnormal. What is normal? Normally the left hyla being higher than the right hyla is normal. Okay. Again, you can see it on the CT correlate also that the left hilum, left pulmonary artery is higher than the right pulmonary artery by around 2 centimeters. Right? Very, very important for you to remember. Again, the normal pulmonary artery impression. Can I see the main pulmonary artery impression on the chest X-ray? Yes, this is the impression of the main pulmonary artery. This is the impression of the main pulmonary artery. So how does the main pulmonary artery actually originates in the heart? So this is the right atrium. This is my right atrium. This is the tricuspid wall. From the tricuspid wall, the right ventricle originates, and this is the level of the pulmonary artery. Here the pulmonary artery originates like this, gives off a left main pulmonary artery, a right pulmonary artery dividing into interlobar arteries. तो एक इम्प्रेशन आता है लंग में मेन पल्मनरी आर्टरी का. दिस इज एन इम्प्रेशन ऑफ मेन pulmonary artery. And if you draw a line from the aortic knuckle to the left heart border, this impression is medial to this line. This impression is medial to this line. Now, in cases of pulmonary arterial hypertension, in cases of pulmonary arterial hypertension, this bulge goes outside this tangential line, number one, and this descending pulmonary artery branch ki width becomes more than 15 centimeters. More than 15 mm, sorry, not centimeters, more than 15 mm. These are findings of pulmonary arterial hypertension on chest X-ray. On chest X-ray. Hi, good evening, Krishna. Krishnavadi, good evening. How are you? तो अगेन एन एग्जांपल ऑफ हाइलर लिम्फेडिनोपैथी. तो इस वाले एग्जांपल में हमने क्या देखा था कि हाइला बल्की है. क्या हाइला बल्की है? यस, हाइला इज बल्की, बट इट इज स्मूथ. इट इज बल्की, द हाइला इज बल्की, बट इट इज स्मूथ. जबकि इस केस में आप देखो, हाइला हैज अ लंपी बम्पी आउटलाइन. ठीक है, द हाइला हैज अ लंपी बम्पी आउटलाइन. तो इसको हम कैसे डिस्क्राइब करेंगे? This chest X-ray, I'll say the trachea is in midline. The cardiac size is normal. The cardiac position is normal. Bilateral hyla are normal in position but bulky in size. They are increased in size with a lumpy, bumpy outline. Okay, this irregular, lumpy, bumpy outlines tells us that underlying यहाँ पर nodes हैं. ठीक है, this lumpy, bumpy outline suggests hilar lymphadenopathy. ठीक है, whereas in cases of pulmonary arterial hypertension, again the hyla is enlarged but it is smooth outline. Okay, so now we move on to the diaphragms. Again, diaphragm impression is pretty easy for us to understand. The right diaphragm is slightly higher than the left diaphragm. कितना higher होता है? Around 2 centimeters. So the difference between the right and the left diaphragm is around 2 centimeters. The right is higher than the left. This is the normal position. In case the left also increases in height like this, then you suggest that either there is a splenomegaly here which is pushing the diaphragm up, or there is left lower lobe collapse which is pulling the diaphragm up. Okay, so either a push from below or a pull from up. This can either be a collapse, fibrosis. ठीक है, कुछ भी हो सकता है, but normally the right hyla is higher than the left hyla. Now from the diaphragm we move laterally, we see the CP angles. Okay, CP angles हम क्या बोलते हैं? They are sharp. If you know your CP angles are like this, then you call them blunted CP angles. Blunted CP angles. ठीक है, क्या क्या कॉज होते हैं CP एंगल ब्लंटिंग की? मोस्ट कॉमन कॉज इज प्लूरल इफ्यूजन. सेकेंड इंपॉर्टेंट कॉज इज प्लूरल थिकनिंग. Pleural thickening. All right. So CP angle stands for costo. Costo means ribs. Costophrenic. Phrenic means diaphragm. Costophrenic angles. Another CP is your cardiophrenic angle. So between the heart, this is the cardiophrenic angle on the right side, and on the left side, cardiophrenic angle. Now from the heart, we now move on to lungs. So the lung fields, this is my right lung and this is my left lung. ठीक है, तो ये वाला मेरा AP व्यू है. दिस इज माय लैटरल व्यू चेस्ट एक्सरे. ठीक है, लैटरल व्यू चेस्ट एक्सरे आपको कोई देगा नहीं एग्जाम में. यू विल ओनली बी गेटिंग AP व्यू चेस्ट एक्सरेज इन द एग्जाम, राइट? नाउ ऑन द राइट हैंड साइड वी हैव टू फिशर. वन major fissure which runs oblique. This is my major fissure, and a horizontal fissure also known as the minor fissure. This is the minor fissure which is horizontal in nature. This divides lung into right upper lobe, right middle lobe, and the right lower lobe. Now right lower lobe तो छोटा नहीं है जितना आपको AB view में दिख रहा है. This is just because there is significant overlap. On the lateral X-ray, this is very well seen separately. So above the horizontal or the minor fissure, we have right upper lobe. Between the horizontal and the oblique fissure, we have right middle lobe, and this is my right lower lobe. Right? Again, you can see significant overlap between the lung lobes. So this is my right upper lobe, right middle lobe, and this is my right lower lobe. पूरा जो मैंने white में दिख रखा है, this is right lower lobe. Right, so you can see that there is significant overlap between the right upper lobe and the right lower lobe on frontal chest x-ray PAV. तो अगर आपको कोई यहाँ पर पैथोलॉजी दिख रही है, ठीक है, इट कैन ईदर बी इन द अपर लोब और इट कैन ईदर बी इन द लोअर लोब. उसके लिए कौन सा व्यू करना पड़ेगा आपको? यू हैव टू डू अ लैटरल चेस्ट एक्सरे. ठीक है, यू हैव टू डू अ लैटरल चेस्ट एक्सरे. Similarly, there is a part of lung which extends beyond the right hemidiaphragm outline. So the right lower lobes in fact goes below the right hemidiaphragm on an AP view. So you can see very well this on the lateral X-ray that the posterior part of the right lower lobe, in fact both lower lobes, is inferior to the dome of diaphragm. This is the dome of diaphragm. ठीक है, dome is the highest part of diaphragm, dome of diaphragm, and उसके नीचे there is a significant part of the lung. This is also forms the hidden area of the lung, right? So lower lobe pathology sometimes may not even be seen on frontal chest X-ray because frontal chest X-ray में ये वाला part cover ही नहीं होता. Somewhere here this lies the lower lobe का lot of part, right? Now on the left hand side we have only one fissure. On the left hand side we have only one fissure, namely the oblique fissure, and which divides into the it divides left lung into the right upper lobe and the right lower lobe. And again you can see that there is significant overlap between the right upper lobe and the right lower lobe on the frontal chest X-ray. So any pathology, let's say here, यहाँ पर कोई pathology आई, it can either be in the upper lobe or the lower lobe. We cannot tell on frontal chest X-ray. उसके लिए क्या करना पड़ेगा आपको? Lateral chest X-ray करना पड़ेगा. ठीक है, कि anterior है कि posterior है, right? So I hope this part of the lungs is clear. Now finally we come to bones and soft tissues. And bones and soft tissues देखना क्यों important है, क्योंकि कभी कभी incidental findings you can pick up on chest x-ray only. So let's say patient को chest pain हो रहा था बहुत टाइम से, chest x-ray appears normal. So इस केस में how will you report this chest x-ray? So as a MBBS student or as an intern, let me tell you how should I report this x-ray. So this is a chest x-ray PA view of a 56-year-old male. The patient is non-rotated. There is adequate exposure. You can very well see the bone outlines, vertebral outlines posterior to the heart. So it is non-rotated film with adequate exposure. The trachea is in midline. Cardiac size and position is normal. Bilateral CP angles are sharp. Bilateral hyla are normal. Bilateral lung fields show normal bronchovascular markings, but there is fracture of the right clavicle. Okay, this is an incidental finding that you can pick up on a chest x-ray. There is right clavicle fracture, right? Now sometimes in female especially, you can see this breast shadow. You can see this breast shadow sometimes in female. Okay, so don't confuse it with a mass in the lung. So these are nothing but normal breast shadows. Breast shadows. And another bone that you have, which you have to look always, are ribs. Okay, so sometimes small rib fractures you can pick up on chest x-ray. So in this case you can see there are multiple left rib fractures, multiple left rib fractures. Okay, now this was regarding the normal chest x-ray. So we talked about the trachea, airways, cardiac outline, hyla, phosphophrenic angle, lung fields, and the bones and soft tissue. And we also discussed which part of the heart, which part of the pulmonary vessel form which contour in the chest x-ray. Now let's come to pathologies of the lung. Once the basics are clear, the pathologies will be very, very easy for us to understand. Now we'll mainly discuss consolidation collapse because this is the most important thing at MBBS level from your prof point of view and as an intern, that you should be able to at least differentiate between consolidation and collapse. We'll talk about patterns of diseases and some important chest x-ray spotters that will be asked in your exam. First of all, what are the various pathologies which can occur in the lung? So one can be consolidation. Consolidation. What is consolidation? Consolidation is basically filling of alveoli. So if this is my lung, right, small alveoli can either get filled with pus, fluid, blood. Okay, so pneumonia, pulmonary edema, pulmonary hemorrhage, all will form consolidation, right? Now this consolidation can either be limited to one lobe, in which it is called a lobar consolidation. It can be diffuse bilateral, okay, in which it is known as diffuse consolidation, और it can be multifocal with ill defined opacities. मतलब यहाँ पर एक ill defined, यहाँ पर एक ill defined, यहाँ पर एक ill defined. We'll see examples of each and every one of these. Another pathology can be collapse or atelectasis. Okay, this is atelectasis. The hallmark of atelectasis is volume loss. So you will see a part of the lung which has loss of volume or loss of air. Another type of opacities can be interstitial. Okay, so between the pulmonary lobules there is thickening, so interstitial opacities, or there can be nodules or mass. Okay, now what is the difference between a nodule and a mass? It is based on size. So less than 3 centimeters you call it nodule, more than 3 centimeters call it mass. And how do you differentiate a nodule or a mass from, let's say, consolidation? You look at the borders. So if the borders are very well defined. It is nodule or a mass. Okay, consolidation has ill-defined borders. Consolidation has ill-defined borders. Mass or nodule has a very well-defined borders. Lobar means, Dr. Prakash is asking, what does lobar mean? Lobar means कि एक lobe involved है. I told you ना in above slide, right upper lobe, right middle lobe, right lower lobe, left upper lobe, left lower lobe. अच्छा मैंने अलग लेबल कर दिया यार. This is left. ठीक है. So lobar means that one lobe, whole lobe is involved with consolidation. So consolidation number one is a radiological finding and it tells replacement of alveolar air by either fluid. So अगर fluid replace कर देगा कौन सी underlying pathology है? Pulmonary edema में मिलता है. अगर blood से replace हो रही है alveoli, then it is pulmonary hemorrhage, or the alveoli can get filled with pus and necrotic infected material, which we call as pneumonia. Sometimes it is just inflammatory cells which fill up the alveoli, as we see in eosinophilic pneumonia, or some other substances. For example, surfactant deficiency में you get pulmonary alveolar proteinosis. If you remember in Robbins, we've read pulmonary alveolar proteinosis. Again, this is an alveolar pathology which presents with consolidation. The hallmark of a consolidation is absence of volume loss. So try to understand if this is my respiratory bronchiole, there are multiple alveoli which are coming out from here. Okay, now pus is getting filled in all of these alveoli, right? So the volume of the alveoli is normal. It is just air is just being replaced by fluid, pus, blood, etc. So the hallmark of consolidation is no volume loss. And this is how a consolidation looks. That you will get a opacity, radio opacity, which is obscuring the underlying vessels. Okay. So how do you see consolidation? Consolidation on a chest X-ray is a radio opacity obscuring vessels. Okay, so here you see a radio opacity which does not have a very well defined borders and it is obscuring your vessel. So this is a consolidation. This is a consolidation. Again, another consolidation you see here. This is a consolidation. This is a consolidation, right? So multifocal consolidations are seen here. So what are the signs of consolidation? Number one is homogeneous opacity obscuring vessels. Number two important sign is an air bronchogram sign. Air bronchogram sign. Now again, come back to this diagram. We discussed that in consolidation, alveolar air gets replaced by either pus, blood, or fluid, but the bronchus, the mainstem bronchus, or the respiratory terminal bronchiole, they still have air within. They still have air within. That is why in a consolidation, you see homogeneous opacity in the alveoli, but air bronchograms are still seen. So in this image, you can see this. This is an air bronchogram. Again, in the second image, the air bronchogram are well seen. This is an air bronchogram, right? So these tell that this is a consolidation. Now, another type of consolidation or another presentation of a consolidation can be ill-defined patchy opacities. Ill-defined is an important word. Patches, it occurs in patches. So again, a homogeneous opacity obscuring vessels, patch, another patch, another patch. This is a big patch. This is a bigger patch. So multifocal ill-defined patchy opacities. This also represents consolidation. And third manifestation of consolidation is airspace nodules, right? These small ill-defined areas. Since they're very, very tiny, they are known as nodules. They are known as nodules, and they are nothing but alveolar consolidation. Okay, alveolar consolidation. ठीक है, तो मान लो ये आपका ट्री था, ब्रोंकियल ट्री, और ब्रोंकियल ट्री था. देयर वर मल्टीपल alveoli. There were multiple alveoli. Some of these alveoli had fluid within or pus cells within. Some did not. Some did not. Right? So these will appear as nodules. These will appear as nodules. And there's special type of nodules that occur here. So if you see a branching pattern of nodules, a branching pattern of nodules, also known as a tree in bud nodules, tree in bud nodules. Now this suggests that there is an endobronchial spread of infection. And most common infection which spreads by this mode is TB. Is TB. Right? So tree in bud nodules happens due to endobronchial spread of infection. Most commonly it is TB. Can also be seen in histoplasma, bronchopneumonia, aspiration pneumonia. Aspiration pneumonia. Okay. Many causes of tree in bud nodules. So three patterns we have read: homogeneous opacity obscuring vessels, air bronchogram sign, ill-defined patchy opacities, and airspace nodules or alveolar consolidations. Now another pattern, this was the pattern. Now another pattern is lobar consolidation. So entire lobe gets homogeneously opacified. This is lobar consolidation. In this case, what do you see? So the right minor fissure or the right horizontal fissure is bulging downwards. This is known as bulging fissure sign. This is known as bulging fissure sign. It is caused by lobar consolidation of the right upper lobe. And which organisms cause it? Klebsiella and Streptococcus pneumoniae. Streptococcus pneumoniae and Klebsiella. Now another pattern can be diffuse patchy consolidation. तो एक यहाँ पर multiple ill-defined patches. This is also known as bronchopneumonia pattern. Bronchopneumonia pattern. And a lot of causes can be there for this. So either bacterial bronchopneumonia, which is the most common type that you see, can be viral pneumonia also, ARDS, or pulmonary hemorrhage. All of these can present with diffuse patchy consolidation. Now third type of consolidation is this perihilar consolidation, right? This is also known as bat wing consolidation. And इसके दो important cause हैं. It has two important cause. Number one is pulmonary edema. And number two is pneumocystis jirovecii pneumonia. Pneumocystis jirovecii pneumonia. इन दोनों में कैसे डिफरेंशिएट करेंगे? इन पल्मनरी एडिमा यू विल गेट एसोसिएटेड प्लूरल इफ्यूजन प्लस कार्डियोमेगली. Because pulmonary edema happens due to back pressure from the heart, so cardiomegaly मिलेगी and pleural effusion मिलेगा आपको. Pneumocystis jirovecii में you do not see pleural effusion. and no cardiomegaly. ठीक है, so batwing consolidation, diffuse patchy consolidation, lobar consolidation. Examples of each of these I have given you. Another pattern can be peripheral consolidation. तो एक था हमारा बैटविंग जिसमें पेरीहाइलर था, मतलब सेंटर की तरफ कंसोलिडेशन था. Another pattern is a peripheral consolidation in which the consolidation is predominantly in the periphery of the lung. ठीक है, periphery of the lung में है consolidation. This is also known as reverse batwing consolidation. इसके क्या एग्जाम्पल है? मोस्ट इंपॉर्टेंट एग्जाम्पल आपको इसका याद रखना है, कोविड 19 निमोनिया. कोविड 19 निमोनिया. सेकेंड इंपॉर्टेंट एग्जाम्पल ARDS. थर्ड इज ऑर्गेनाइजिंग निमोनिया. थर्ड इज ऑर्गेनाइजिंग निमोनिया, पेरिफेरल कंसोलिडेशन और batwing consolidation. Now, how does aspiration in pneumonia looks like? So I have already told you one thing about aspiration pneumonia, not aspirational. Aspiration pneumonia राइट में ज़्यादा कॉमन होगा कि लेफ्ट में? Which lung will aspiration pneumonia be more common, right or left lung? Good. So Manade is absolutely right. It is more common on the right side. Why? Because the right mainstem bronchus is more vertical. The left mainstem bronchus is more horizontal. So aspiration pneumonia right side ज़्यादा common होता है. Now, now right side में एस्पिरेशन निमोनिया की क्या क्या साइट्स होती हैं इंपॉर्टेंट? तो साइट्स, so the sites are different on depends on whether the patient is supine या recumbent or whether he is erect. So in a supine or a recumbent position, the most common site is posterior segment of right upper lobe and superior segment of right lower lobe, right? Whereas in the erect position, it is more common in the basal segments and right middle lobe or the lingula of left upper lobe. Lingula of left upper lobe. Okay, so these are the common sites of aspiration pneumonia. Now let's come to collapse. So consolidation में air alveoli in the air was getting replaced by either fluid, pus or blood. In collapse, that air is completely lost. There is decrease in the amount of air within the alveoli. So the hallmark of collapse will be loss of lung volume. Okay, very, very important. Consolidation, lung volume is preserved. Collapse, lung volume is lost. Right? What are the signs of collapse on chest X-ray? I've enumerated the signs. We'll see in subsequent slides each and every sign. Right? So displacement of fissures. So right minor fissure pulling up, again sign of collapse. Crowding of vessels on CT. Diaphragm elevation, I've already told you, elevate होगा diaphragm मतलब कोई pull कर रहा है उसको. Hilar displacement, again sign of volume loss. Mediastinal shift, crowding of ribs, and sometimes air bronchogram can be seen, although it is more common in consolidation. More common in consolidation. So the hallmark is loss of lung volume. Loss of lung volume. Now, in this example, you see that the right minor fissure is pulled up. The right minor fissure is pulled up. The right hemidiaphragm is getting tented like this, and the right hyla is elevated. Okay, that means that there is loss of volume in the right upper lobe. So this suggests a right upper lobe collapse. So what are the signs that we see here? We see pulling up of minor fissure, elevation of right hilum, tenting of right hemidiaphragm. Okay, signs of right upper lobe collapse. Now, in comparison, in the next image you see, in the next image, it is a very subtle finding, and that's why this type of collapse is very subtle for you to pick up. In this, we see that the left main bronchus is somewhat more horizontal than is normally seen. It is more horizontal than is normally seen. And behind the heart, there is some increased opacity. And if you zoom in, you can see this sickle shaped segment of air, the sickle shaped segment of air surrounding the aortic knuckle. Okay, this has a very important sign. This is known as Luftfischl sign. Sorry for that. This is known as Luftfischl sign. And these all are signs of left upper lobe collapse. Left upper lobe collapse. Okay, so you can see that the left bronchus is pulled up. And another finding, if you can see, if I forgot to add it, the left hilum is also pulled up. The left hilum is also unnaturally pulled up. So, what are the signs of left upper lobe collapse? Number one is Luftfischl sign, elevation of left hilum. Number three, elevation of left main bronchus. Right now, in comparison, in this image, you can see in the third image, what do you see? That there is this line, this radiopacity, which is near the right heart border and it is obscuring your left hemidiaphragm outline. And on the lateral x-ray, if you zoom in on the lateral x-ray, there is this radio opacity in the right lower lobe. So this is my right lower lobe collapse. So collapse जब भी होगा, whenever there is collapse, there will be volume loss. So either elevation of hyla, elevation of diaphragm, pulling up of the left main bronchus, all of these are signs of collapse. Right? Now this is an important sign. So what are the findings in this chest X-ray? If I were to describe this chest X-ray, I will say the trachea is in midline, or I'll say the trachea is slightly deviated to the right hand side here. Okay, this was the midline. It is slightly deviated to the right hand side. The trachea is slightly deviated to the right hand side. Cardiac size is normal. Cardiac position is normal. CP angles are really not seen, but they appear to be sharp. Now, in the lungs, what can I see? I can see that there is a homogeneous radiopacity in the right upper lobe. The right, the right minor fissure is pulled up on the lateral end, whereas on the medial end, it is bulging down. Okay, I'll say that there is homogeneous radiopacity on the right upper zone, The right minor fissure is pulled up on the lateral aspect and it is bulging down on the medial aspect. This important sign is known as golden S sign. Golden S sign, and it is formed due to right upper lobe collapse. ठीक है, राइट माइनर फिशर पुल्ड अप था मतलब राइट अपर लोब कोलैप्स है, एंड जो बल्ज है नीचे, दिस बल्ज इज ड्यू टू अ central hilar mass. यहाँ पर there is a mass sitting here which is causing bulging downwards. What is this mass? Most commonly to describe the sign, this was a bronchogenic CA. So right upper lobe collapse with bulging medial part of minor fissure seen in bronchogenic carcinoma. Bronchogenic carcinoma. Right? Now, in this chest X-ray, second chest X-ray, what do you see? Trachea is in midline, cardiac size, cardiac position is normal. I see a radiopacity in the right lower zone. I see a radiopacity in the right lower zone, obscuring the right heart border. So, right heart border obscured. What is the location? Whenever, remember, जब भी right heart border obscure होता है, the pathology is in the right middle lobe. The pathology is in the right middle lobe because, as you can see in the previous images that we discussed, okay, right medial lobe RML is just abutting the right heart border. So which part of the lung abuts the right heart border? It is the right middle lobe RML. Okay, so whenever there is pathology in the right middle lobe, either a collapse or a consolidation, the right heart border outline will be obscured. Right? This is the basis of silhouette sign that we'll subsequently read. Right? So this was the pattern of consolidation and pattern of disease in a lung collapse. Now, how do you localize consolidation or collapse? For localizing, we use the silhouette sign. So some part of silhouette sign I've already told you in the previous slides. What is a normal silhouette? Silhouette is nothing but the outline. Outline. So silhouette sign is nothing but obscuration of normal outline of mediastinal structures. ठीक है, अब प्री रिक्विजिट क्या है कि जो भी आउटलाइन मीडियास्टाइनम की ऑब्सक्योर होगी, द डेंसिटी ऑफ दैट स्ट्रक्चर एंड द पैथोलॉजी शुड बी सेम. It should be same. Right? So let's read and understand which part of the lung abuts which part of the mediastinum. So right upper lobe abuts the right paratracheal stripe. The right paratracheal stripe. So in cases of right upper lobe collapse, right upper lobe consolidation, the right paratracheal stripe will be obscured. Again, you can see similarly here, जब हम right upper lobe collapse पढ़ रहे थे, the right paratracheal stripe was obscured. Again, in this image, the right paratracheal stripe was again obscured because it is abutting the right upper lobe. In case of right middle lobe, which part will be obscured? The right heart border. We have just seen in this example. The right heart border was obscured by this right middle lobe collapse. Now, in case of a right lower lobe collapse, what part will be obscured? Now, here the diaphragm will get obscured. On the left hand side, the left upper lobe is in contact with the aortic arch. So left upper lobe consolidation, left upper lobe collapse, aortic arch की outline will be obscured. लेफ्ट हार्ट बॉर्डर कब ऑब्सक्योर होगा? जब अगेन पैथोलॉजी होगी हमारी लिंगुला में. लिंगुला इज अ पार्ट ऑफ लेफ्ट अपर लोब. एंड लेफ्ट लोअर लोब कब ऑब्सक्योर होगा हमारा? लेफ्ट हेमी डायफ्राम विल बी ऑब्सक्योर्ड इन पैथोलॉजीज ऑफ लेफ्ट लोअर लोब. And along with left hemidiaphragm, any other structure whose outline will be obscured? Yes, the descending aorta. This is also in the left lower lobe. So iski bhi outline obscure ho jayegi whenever there is left lower lobe collapse or consolidation. Let's see the examples of each. Now here, what do you see? There is a radio opacity. How will I describe this X-ray? The trachea is in midline, cardiac size is normal, cardiac position is normal, right? I see a radio opacity in the right middle and right lower zone of the chest. And the right heart border can be well seen. Right heart border is well seen, which you can see by the short arrows. But the right diaphragm की outline बहुत अच्छे से नहीं दिख रही है. That means that this part of the lung which is getting consolidated slash collapse, most likely consolidated, it is involving the right lower lobe because that part is in contact with the right hemidiaphragm. So this tells you that the right lower lobe is involved. Similarly, if my paratracheal stripe here is getting obscured, the pathology is in the right upper lobe. If my right heart border is getting obscured, pathology is in the right middle lobe. On the left hand side, if my left heart border is getting obscured, pathology is in the left upper lobe lingular segment. And if my heart border, aortic knuckle, both of them are getting obscured, pathology is in the left upper lobe. And again, if the left hemidiaphragm is getting obscured, the pathology is in the left lower lobe. Pathology is in the left lower. So this is the basis of silhouette sign. Remember this diagram, very, very important for you to understand. Now tell me, how will you describe this X-ray? How will you describe this X-ray? Okay, so first tell me, is it a AP view or a PA view? This is an AP view because हमारे hand side में है. The hands are on the sides, right? Humerus side में पड़ी है. So this is an AP view. So this is an AP view chest X-ray of let's say a 36-year-old male. Male क्यों है? क्योंकि breast shadow नहीं दिख रही. AP chest X-ray of a 36-year-old male. The trachea is not in midline. Okay, also the film is rotated and there is poor exposure क्यों? क्योंकि हमें पीछे की वर्टिब्रा नहीं दिख रही है, right? Now how will I further tell its description? The trachea is not in midline, the trachea is deviated to the right. The cardiac silhouette is also deviated to the right. So both the trachea and the cardia are deviated to the right. So there is tracheal shift and there is mediastinal shift. There is mediastinal shift plus there is tracheal shift. Now let's come to the diaphragms. The right hemidiaphragm outline is obscured. The right CP angle is obscured. I see a homogeneous opacity in the right hemithorax. So there is a right opaque hemithorax. I see a homogeneous opacity in the right hemithorax obscuring the vessels. No air bronchograms is seen. No air bronchogram is seen. Now you see a homogeneous opacity, you see shifting of trachea, you see shifting of mediastinum. What is this? This is entire right lung collapse. This is right lung collapse. Okay, both right upper, middle and lower. Lower की भी pathology है. Why? Because the right hemidiaphragm is obscured. ठीक है बुकर? So right upper, middle and lower lobe pathology. Collapse of right entire lung. Okay, now let's come to few important radiology spotters. First, we'll see how to describe this image because that is how your viva will go. So this is the AP PAE होगा. PAE है. Why? Because the hands are rotated laterally. So this is a PA X-ray of the chest with the medial end of the clavicles are approximately equidistant, so no rotation. There is good exposure. I can see the vertebral bodies. Okay, so this is a PA view of the chest X-ray in a, let's say, 36-year-old male with adequate exposure and a non-rotated film. The trachea is in midline. Cardiac size and position is normal. Bilateral CP angles are clear. Now, what is the main pathology? The main pathology is in the lungs. So I see a cavity. तो इसको डायरेक्टली आपको बोलना है आई सी अ कैविटी इन द राइट अपर एंड मिडिल जोन. Now, with this we come to zones of lung. Zones of lung. So in the previous slides, when I told you, okay, we can see significant overlap. There's significant overlap between the right lobe and the right lower lobe. So saying lobes on left X-ray is not really correct. How do we describe any pathology on an X-ray? We divide into zones. The left X-ray is divided into equidistant zone. This is the upper zone, the middle zone, and the lower zone. Normally, these zones are based on your anterior intercostal spaces. So if this is my first rib, this is my second rib, this is my third rib. ठीक है. सो जब भी आपको एग्जामिनर बोले रिब काउंटिंग करो, रिब काउंटिंग हैज टू बी ऑलवेज anterior to posterior. Rib counting has to be anterior to posterior, right? So on the left hand side, again, let's see on the left hand side, which is the first rib. This will be the first rib. This will be the second rib. This will be the third rib. So first, second, and the third rib. So first and second intercostal space तक अपर जोन है, थर्ड फोर्थ इंटरकॉस्टल स्पेस तक मिडिल जोन है, एंड फिफ्थ सिक्स इंटरकॉस्टल स्पेस तक लोअर जोन है. सो दिस इज हाउ वी डिवाइड इट एक्चुअली, राइट? बट फॉर द सेक ऑफ कन्वीनियंस यू कैन डिवाइड इट इनटू थ्री इक्वल पार्ट. दैट्स आल्सो ओके, राइट? तो दिस वाज रिगार्डिंग लंग जोन्स. जब भी हमें कोई पैथोलॉजी बतानी है हम जोन्स के हिसाब से बताएंगे, लोब्स नहीं बोलेंगे, लोब्स नहीं बोलेंगे. Normally, I need to also remember one thing, that the anterior ribs नॉर्मल लंग वॉल्यूम. हम कैसे बोलते हैं कि हाइपर इन्फ्लेटेड लंग्स हैं कि नॉर्मल लंग वॉल्यूम्स हैं? तो नॉर्मल लंग वॉल्यूम में एंटीरियर 6 रिब्स एंड पोस्टीरियर 8 रिब्स, दे शुड कट द डायफ्राम. ठीक है, इसका क्या मतलब है कि जैसे राइट साइड पर वी वर ड्राइंग रिब्स 1 2 3. So this is the fourth rib, this is the fifth rib, this is the sixth rib, this is the seventh rib. So 4 5 6 7. Here the seventh rib is cutting the diaphragm. That means that lung volume is slightly increased. This is a hyperinflated lung field. This is a hyperinflated lung field. Posterior rib का क्या मतलब है? Posterior ribs, let me label the posterior view. This is the first rib, the second rib, third, fourth, fifth, sixth, seventh, एट्थ, नाइन्थ, 10th. अब 10th पोस्टीरियर रिब जाके डायफ्राम को कट कर रही है. तो दिस इज अ हाइपर इन्फ्लेटेड लंग. ओके, so this is how you see error with voice and video. Is it fine now? तो यहाँ पर 10th posterior rib and 7th anterior rib was cutting the diaphragm. So this is the case of hyperinflated this is the case of hyperinflated lung field. Hyperinflated lung field. Okay. Now coming back to our case. Coming back to our case. What was seen? We a cavity. We see a cavity. कोई air containing in वाला होगा cavity. We see a cavity in right upper and mid zone with the air fluid level. This horizontal line is an air fluid level. Okay. So what are the findings? The findings are cavity in the right upper and mid zone of lung. Diagnosis batao. Tell me the diagnosis with air fluid levels. Diagnosis lung abscess. Diagnosis is lung abscess. Is the network fine now? Can someone yeah, is the network fine? The first spotter is that of a lung abscess, cavity in the right upper and mid zone with air fluid level. This is lung abscess. Now the next spotter. Next spotter, how will we describe it? So this is a PA chest X-ray, chest X-ray PA view of let's say a 25-year-old male. It is a non-rotated film with adequate exposure. Trachea is in midline. The cardiac size and shape is normal. Cardiac position is normal. Bilateral diaphragms are normal in position. Bilateral costophrenic angle or CP angle are normal. Now, the main pathology is in the lungs. In the lungs, we already described this. I see multiple defined fascies in the right upper zone with multiple nodules. With multiple nodules. So क्या है? Right upper zone, ill-defined, fluffy opacities plus random nodules. रैंडम हटा देते हैं प्लस नोड्यूल्स. ठीक है. तो इल डिफाइंड फ्लफी ओपेसिटीज क्या बताती हैं? कंसोलिडेशन एंड नोड्यूल्स. तो नोड्यूल्स हैं. नोड्यूल्स टेल्स अस एयर एल्वुलर कंसोलिडेशन. राइट. तो क्या डिजीज चीज है राइट अपर जोन में अगर आपको कंसोलिडेशन मिलता है विद नोड्यूल्स, व्हाट डू यू हैव टू सस्पेक्ट? यू हैव टू सस्पेक्ट ट्यूबरक्यूलोसिस. You have to suspect tuberculosis. Very, very important. So tuberculosis, especially reactivation, reactivation TB, also known as secondary TB. Secondary TB. This affects the upper zones, right more than left. ठीक है, लेफ्ट में भी हो सकता है, राइट में भी हो सकता है, दोनों में भी हो सकता है. अपर जोन्स मोर कॉमन देन द लोअर जोन्स. दिस इज टीबी. ठीक है. नाउ टीबी में विल स्पेंड अ लिटिल टाइम बिकॉज टीबी एक्सरेज आर वेरी वेरी कॉमनली आस्क्ड इन वाइवास, इन लॉन्ग केसेस, इन प्रॉफ एग्जाम्स. In internship also you will see a lot of TB cases, TB x-rays being asked, right? So infective focus in the right upper lobe which heals itself, gets calcified, and there is an ipsilateral mediastinal or a hilar lymphadenopathy. तो अगर इस चेस्ट एक्सरे को हम डिस्क्राइब करें, हाउ विल यू डिस्क्राइब दिस चेस्ट एक्सरे? दिस इज अ चेस्ट एक्सरे PA व्यू. अगेन PA व्यू क्यों? क्योंकि आई कैन सी द humerus being deviated outside. So patient is holding the x-ray like this, bucky like this. So this is a chest x-ray PA view of this 30-year-old male. The film is non-rotated. It is overexposed. It is underexposed. ज़्यादा white दिख रहा है ना हमें, पीछे की vertebra नहीं हम देख पा रहे हैं. So this is underexposed film. ठीक है. Now what do I see? The trachea is in midline. The cardiac size and position is normal. Bilateral diaphragm are normal. CP angles are sharp. CP angles are sharp. Now the main pathology is there is thickening of the right paratracheal stripe. There is thickening of this right paratracheal stripe, and I can see that the right hyla is bulky. The right hyla is bulky. Okay, what are these? This bulky hyla has a lumpy bumpy outline. So this is right hilar lymphadenopathy along with right paratracheal lymphadenopathy, right? So primary TB mainly presents in adults. हम adults की बात कर रहे हैं. In adults, primary TB mainly presents as mediastinal and or hilar lymphadenopathy. Okay, primary TB predominant finding is lymphadenopathy, not lungs. Lungs are more commonly affected in secondary TB or post-primary TB or reactivation TB. Primary TB में predominant finding on chest X-ray is a mediastinal or hilar lymphadenopathy. Very very important question for you, for all of you. Okay. Now it can have two fates. Either primary TB can get healed. This is seen in immunocompetent patients. ओके, तो हील हो जाएगा प्राइमरी टीबी. तो कैसा दिखेगा आपको? हील होता है ये स्कारिंग से. तो यू कैन समटाइम्स सी एपाइकल प्लूरल थिकनिंग. ओके, नो कंसोलिडेशन, नो नोड्यूल्स, जस्ट apical pleural thickening. This tells you a healed primary TB. Now, in an immunocompromised patient, this primary TB can spread. This primary TB can spread throughout the lungs. So you can see small, small millet-shaped nodules, very tiny nodules, millimeter. So you can see tiny nodules throughout lung, throughout the bilateral lungs. This tells you that there has been a hematogenous spread. means the bacilli has spread via the blood throughout the lung. This is known as miliary TB. So millet-shaped size nodules scattered randomly throughout the bilateral lungs, and not just lung. In fact, it goes into the liver, spleen, abdominal lymph nodes, etc. So throughout the body. Okay, this is miliary TB. This is miliary TB. Now, in a post-primary TB, now post-primary TB happens when that if this healed or immunocompetent patient again develops an immunocompromised state, immunocompromised. कब हो सकता है immunocompromised? Either malnutrition, ठीक है, और chemotherapy, cancer, immunotherapy, immunosuppressants. If any immunocompromised, diabetes, even if mild immunocompromise happens, then this gets reactivated. TB reactivation. This is also known as post primary TB. TB reactivation or post primary TB. TB reactivation or post primary TB. Now, post primary TB is very, very interesting. What typical findings in a post primary TB we see are lung findings. In a post primary TB, the predominant findings are lung findings. Okay, and here the upper lobes are involved more than the lower lobes. More than the lower lobes. Now, in a post-primary TB, what are the findings? So you can either get consolidations, nodules. तो बेसिकली स्टार्ट कैसे होती है पैथोलॉजी? पैथोलॉजी एक नोड्यूल से स्टार्ट होती है, फिर मल्टीपल नोड्यूल्स कोलेस ज्वाइन कर लेते हैं, फॉर्मिंग अ कंसोलिडेशन। फिर इस कंसोलिडेशन में क्या होता है, नेक्रोसिस सेल्स आके एक कैविटी बना देती हैं सेंटर में दे फॉर्म अ कैविटी तो कंसोलिडेशन, नोड्यूल्स, कैविटेशंस, प्लूरल इफ्यूजन्स, नेक्रोटिक mediastinal and hilar lymph nodes. Okay, so all these are findings of a post primary TB. So nodule से start होता है, consolidation होता है, breakdown होकर cavitation होता है, pleural effusion happens and necrotic mediastinal and hilar lymphadenopathy happens. Now special type of nodules develop in TB which are known as tree in bud nodules. So you can see that there is this there is this vessel or an adjacent bronchi, and adjacent to it the nodules are lying like a branch. Okay, जैसे tree in bud की appearance होती है, this is a tree in bud appearance of nodules. This is also known as ventrilobular nodules or tree in bud nodules. क्या importance है? What is the significance? It tells you that there is endobronchial spread of TB. एंडोब्रोंकियल स्प्रेड हो रहा है, मतलब बैसिला एक जगह से ब्रोंकस के थ्रू दूसरे पार्ट ऑफ लंग में जा रहा है, एंड दिस टेल्स यू दैट दिस पेशेंट इज इन्फेक्टिव. एंडोब्रोंकियल स्प्रेड है मतलब इन्फेक्टिव है पेशेंट अभी, राइट? नाउ दिस इज एन एग्जांपल ऑफ अ कैविटी, so a round opacity with a central air containing structure. This is a cavity. Again, this is a cavity and surrounding consolidation. Surrounding it is the consolidation, and these are your numerous nodules, multiple nodules, right? Now, how does your lymphadenopathy looks on CT scan? So this is how your lymphadenopathy looks like. These are enlarged lymph nodes. These are enlarged lymph nodes that you see on CT scan. So all these are findings of a post-primary TB. Okay. Now I'll give you another chest X-ray. Again you see multiple nodules. यहाँ पर है, 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 यहाँ पर upper lobe and mid zone दोनों में है. Again this is a case of TB. Here the nodules are in bilateral lungs. So right में भी है, left में भी है. Again this was a case of tuberculosis. And again here you see that there is a cavity. यहाँ पर ये cavity है. This is a cavity and multiple nodules are seen. यहाँ पे consolidation, cavity. So all this is tuberculosis. All this is tuberculosis. ठीक है? Any doubt in tuberculosis? Please put them in the chat. Okay. Now we'll come to a third spotter, that is pleural effusion. Now pleural effusion में कैसे दिखेगा आपको? Homogeneous opacity मिलेगी, but how will you differentiate it from a consolidation or a collapse? You will see this meniscus sign. ठीक है? This is your meniscus sign. ठीक है? This tells you that there is pre-pleural effusion. Sign is meniscus sign. Diagnosis is pleural effusion. Investigation of choice. जब भी fluid containing pathologies होंगी, always investigation of choice will be ultrasound. It will be ultrasound. Now, how much fluid can an ultrasound detect? Up to 5 ml also. Ultrasound can detect pleural effusion. Chest X-ray के लिए कितना चाहिए हमें? 150 ml तक minimum fluid to be detected on chest X-ray. ठीक है. Now initial findings क्या होती हैं हमें? Initial findings on chest X-ray, you see blunting of CP angle, right? What is the CP angle? On the right hand side the CP angle is sharp, but on the left hand side there is blunting followed by meniscus sign. This is left pleural effusion. Now next spotter, what do I see here? I see that the lung here is collapsed. And outside it there is increased blackness. So this is not pleural effusion because that will have radio opacity. This is radiolucency, and here I do not see any vessels. Vessels are absent. So this is free air in the pleural cavity or pneumothorax. So this line that you can appreciate, can you appreciate this line? This is my visceral pleural line. Visceral pleural line. Again, on this CT scan, you can see that this is the air and this is the lung, which signifies the pneumothorax. And ultrasound pe, so diagnosis is pneumothorax. Okay. Now, investigation of choice for all air containing pathology is NCCT. It is NCCT. And ultrasound signs क्या क्या होते हैं? Ultrasound signs of pneumothorax can sometimes be asked. पहली बात, अल्ट्रासाउंड करते क्यों हैं हम? इन विच केसेस डू वी डू एन अल्ट्रासाउंड? वी डू इट इन trauma setting. We do it in trauma setting when the patient is not shiftable for a CT scan, let's say. ठीक है? तो अल्ट्रासाउंड में what is the sign of pneumothorax? Sign is barcode sign, also known as stratosphere sign. And how does a normal lung appear on ultrasound? Normal lung shows a seashore sign. Normal lung shows a seashore sign. Okay. Now let's come to quarter number 5. Now how will I describe this chest X-ray? I'll say this is a chest X-ray PA view of a 36-year-old male, non-rotated film with adequate exposure. Now what are the other findings? The cardiac silhouette is normal in position. Bilateral CP angles were not well seen here. The left CP angle, is not seen. Okay, there is obscuration of the left CP angle, and I see an air fluid level. In the left hemithorax. Now, whenever you see an air fluid level and the entire left side lung is black, it is black. That means that there is a left pneumothorax. But since there is an air fluid level associated with it, that signifies there is a fluid within this pneumothorax. So what is this known as? Hydropneumothorax. Remember, hydropneumothorax, that is both air and fluid in the pleural cavity, will show air fluid levels. Hydropneumothorax. Now next spotter, tell me how will you describe it in your viva? This is a chest X-ray PA view of a 55-year-old male. It is a non-rotated film with adequate exposure. The trachea is in midline. Cardiac size is normal. Cardiac position is also normal. Bilateral CP angles are sharp. Now, in the lung fields, I can say that the hyla appears to be slightly bulky. Yes, I'll give you that. The hyla appears to be slightly bulky. So there might be some hylar lymphadenopathy also. But the main pathology is here. There is a cavity. Yes, there is a cavity which has a homogeneous round radio opacity within. And there is this crescent of air in between the cavity and the radio opacity. This crescent of air is there. Now this sign is known as, साइन का नाम है एयर क्रिसेंट साइन, also known as Monod's sign. And the diagnosis is aspergilloma. ठीक है. Now aspergilloma, remember इसके clinical features में क्या मिलेगा आपको? History of hemoptysis, in fact massive hemoptysis. History of massive hemoptysis and past history of treated tuberculosis. तो टीबी की जो लंग कैविटीज होती हैं, in the lung cavities of TB, this aspergillus fungus makes it home and forms a fungal ball. So aspergilloma is nothing but a fungal ball of aspergillus fungus, and it slowly erodes the wall and causes hemoptysis. So it is an important cause of hemoptysis in a post TB treated patient. Okay, so hemoptysis is also a symptom of TB in a post TB treated patient. If there is no fever but just massive hemoptysis, you suspect a aspergilloma. Now next spotter, let's move on to the next spotter. How will I describe it? This is a chest X-ray PA view with adequate exposure, non-rotated film. Trachea is in midline. Cardiac size and silhouette are Normal. Bilateral CP angles are sharp. Main pathologies, yes, the hyla appears to be slightly bulky on both sides. Main pathology is this finger-like radiopacities in the upper lobe. This finger-like radiopacity. What is this sign? बस स्पॉटर्स में आएगा, दिस केस नहीं पूछेंगे आपसे. साइन इज फिंगर इन ग्लव अपीयरेंस. Finger in glove appearance. Diagnosis is allergic bronchopulmonary aspergillosis और ABPA. और क्या क्वेरी होंगी क्लिनिकल फीचर्स में? इस तरह से पेशेंट आता है, हिस्ट्री ऑफ एस्थमा और सम एलर्जी. ओके. और क्या हिस्ट्री हो सकती है? हिस्ट्री ऑफ फटीग, वेट लॉस. हिस्ट्री ऑफ फटीग और वेट लॉस. सो एक्चुअली व्हाट हैपेंस है, द अंडरलाइंग पैथोलॉजी क्या है? अंडरलाइंग पैथोलॉजी इज bronchial dilatation plus mucus plugging. Now next spotter पे आते हैं. What do you see here? Here you see that the intrapulmonary airways are dilated. देखो यहाँ पर ही dilated है. The intrapulmonary airways are dilated. So this is bronchiectasis. Dilatation of intrapulmonary airways. Okay. Now, two important signs you remember. Just name of the signs are fine because that will be only asked from you. Number one is tram track sign, and number two is signet ring sign. And clinical features में आपको क्या मिलेगा? Again, past history of TB, past history of TB or any other lung infection. And second important point, copious amount of sputum production. Copious amount of sputum production. These are the clinical features of bronchiectasis. The signs are tram track sign or signet ring sign, and you see multiple dilated airways within the lungs. Okay, ये image आप याद रख लो. This is how your bronchiectasis looks like. Finally, let's come to the last spotter of this chest X-ray. What do you see here? How will I describe this chest X-ray? I'll say that this is a PA view of PA view chest X-ray of this patient. It's a female. I can see the breast shadow. Okay, so let's say this is a PA view chest X-ray of a 50-year-old female. A non-rotated film, slightly underexposed. Trachea is in midline. Cardiac size in position is normal. Bilateral कॉस्टोफ्रेनिक एंगल अपीयर शार्प. ठीक है, ये एक यहाँ का है, ये यहाँ का है. Main pathology is in the lungs. I see multiple well-defined radio opacities, or I can just directly say masses. Multiple variable size masses scattered throughout the lung. These are known as cannonball metastasis. Okay, cannonball metastasis. And which cancers, कौन से कैंसर में मोस्टली दिखते हैं ये? रीनल सेल कार्सिनोमा, कोरियो कार्सिनोमा. That any cancers, most commonly RCC and कोरियो carcinoma में दिखते हैं, but any cancer which spreads to the lung, can form these large cannonball mets. Can form these large cannonball mets. Okay. So with this, we complete our chest X-ray series. We complete the chest X-ray series and the important X-ray spotters which will be asked from you. Right. So in respiratory radiology, chest X-ray and spotters, if you have any query, please mention them in the chat box. Abukar, Divya, Gaurav, everything fine? Are you still there? Somebody give me a heads up. Somebody give me a feedback. समझ आ रहा है जो पढ़ा रहे हैं? Okay. So we now just now we'll go on to approaching a bone lesion, and I'll mainly talk to you about how to stay a proper bone lesion in your exams. Okay. So let's say you are shown a X-ray of a bone tumor. Now bone tumors you'll cover in orthopedics. I've also covered them in the main videos. You can watch them, but this class is not mainly it's not for MCQ point of view. It is mainly for your Prof Viva exams. How you describe a bone tumor. So whenever you're describing a bone tumor, so first of all tell the bone which is involved, then the location. Okay. First of all tell the age. First of all tell the age, description of X-ray. कि कहाँ का है, कि फीमर, टिबिया, फिबुला, हैंड्स, फेस, चेस्ट, पेल्विस, फीमर, व्हाट, राइट. डिस्क्रिप्शन ऑफ एक्सरे मतलब कहाँ का है, द बोन इन्वॉल्व. Then tell the location. Location is very very important. Okay. Location can either be your epiphysis, metaphysis, or diaphysis, right? Or it can either be in terms of central tumor versus eccentric tumor, center or off center. Let's say this will be a centric tumor, this will be an eccentric tumor. ठीक है ना. Now what is epi, meta and diaphysis? So if this is my joint line, this is my joint line, the part of bone just adjacent to the joint line is the epiphysis. Now in a non-fused chest X-ray, in a non-fused skeletal X-ray, that is before puberty, you'll see a clear space. You see a clear space. This is my growth plate. Now just above the growth plate, you have your metaphysis, and finally the shaft of the bone. That is your diaphysis. So you have to tell the craniocaudal location of the bone tumor as well as the axial location. So whether it is centric or eccentric or epi, meta or diaphysis. This is with respect to your location. Right. Now, fourth thing that you have to say is the internal characteristics. Now, internal characteristics में बहुत सारी चीजें आती हैं. So number one, whether it is a sclerotic or a lytic bony lesion. Second, the margins of lesion. Now margins को ही हम बोल देते हैं zone of transition. Zone of transition. Third thing, you have to tell the periosteal reaction. Then you have to tell presence of a cortical breach. and finally any soft tissue invasion. Okay, so all these are all the points in which you should describe any bone tumor. So first tell the age of the patient, the description of the X-ray, which part of the X-ray is given. So this is an X-ray of knee of this flana aged patient. The bone involved, which bone is involved, tibia is involved, and the location, which part of the bone is involved, epi, meta, or diaphysis, and what type of a bony lesion it is. If it is sclerotic lesion, sclerotic meaning a white lesion, and lytic meaning a black lesion. So chest X-ray may we use the term opacity and radiolucency. In bones, we use the term sclerotic versus lytic. Okay, so any bright white area, ossified bone tumor, this will be my sclerotic bony lesion. This is sclerotic bony lesion, and this will be my lytic lesion. So if I were to describe this X-ray, I will say that this is a X-ray of the knee. I can also say this is the right knee since the fibula is outside. This is the right knee. This is an X-ray of the right knee, AP view. AP view क्यों? क्योंकि this is an AP view. This is an X-ray AP view of the right knee. I can see a lytic lesion in the upper end of the tibia involving the epiphysis and the metaphysis. So both epi and metaphysis are involved. It is showing ballooning of the cortex. Ballooning of the cortex. The margins are sharp. That is, it is well defined. It is well defined, and there is no significant extra osseous soft tissue is present. Now, periosteal reaction is also not significant. Okay, periosteal reaction is normal, and etc. etc. We'll describe each chest X-ray as we go forward, right? So, any description of a bone tumor, if I were to describe any bone tumor, its diagnosis depends on age, location, and your internal characteristics. Okay. Now, in few internal characteristics which are associated with a malignant lesion. Now, malignant meaning an aggressive lesion. Naturally, an aggressive lesion will have what? It will show cortical breach. That is, it will go and break the cortex. It can show extra osseous osseous soft tissue, and it can show a malignant periosteal reaction, a malignant periosteal reaction. These are signs of a malignant bone tumor, that it is so aggressive, it is breaking the cortex, it is forming an extra osseous soft tissue, and it is showing some malignant periosteal reaction. What are important malignant periosteal reaction? Number one is Codman's triangle. Number two is sunburst periosteal reaction. And number three is onion skin periosteal reaction. Now, this Codman's triangle and sunburst periosteal reaction is seen most commonly in osteosarcoma, and this onion skin periosteal reaction is most commonly seen in Ewing's sarcoma. Right? So, these are the main characteristics with which we'll go ahead and learn all the tumors. Now, age, how do you determine age on a skeletal X-ray? So, this is the growth plate that you see. This white fine line, this black line, sorry, this is my growth plate. So, if you are seeing the growth plate, it means it is skeletally immature. Skeletally mature patient, or this, in fact helps us skeletally immature skeleton. Oh, patient. So basically a child, right? And if the growth plate is fused, that means that it is an adult. Growth plate fused, meaning an adult, right? So fused the bone tumors that we'll subsequently read are more common in the children, others are more common in the adults. Epi, meta, and diaphysis we've already covered. What are the bone tumors which mainly occur in the epiphysis? Remember two. Number one is chondroblastoma. It happens in the epiphysis. And second is giant cell tumor. Giant cell tumor. Now, chondroblastoma happens in children. Giant cell tumor happens in adults. Okay. Now, most of the tumors happen metaphysis. So I'm not giving you any specific list. Many bone tumors. Diaphysis has important bone tumors जिसका हम list बना लेते हैं. So important bone tumors in diaphysis are Ewing's sarcoma, adamantinoma, osteoid osteoma, fibrous dysplasias. Now metastasis, lymphoma, LCH, Langerhans cell cytosis, all of these have almost similar appearance. So you can't differentiate based on the imaging. So I'm writing it together. So important is Ewing's, adamantinoma, osteoidostoma, and fibrous dysplasia. Now few of the tumors are now centric. कौन से होते हैं जो सेंटर में होते हैं of the bone? So simple bone shift is centric. Enchondroma and fibrous dysplasias. These are centric bone tumors. Eccentric bone tumors, most important you have to remember is giant cell tumor. Others are FCD, non-ossifying fibroma, aneurysmal bone cyst, and chondromyxoid fibroma. All right. Now, zone of transition. Zone of transition is a very important concept. It is nothing but the transition between your abnormal bone and the normal bone. So this is your normal bone. This is your pathology or your abnormal bone. What is the transition? So if it is narrow, that means that it is very well defined. It means that it is a well defined lesion, implying it is a benign pathology. Benign pathology. Whereas if the transition is ill defined, that is, this is your abnormal bone, this is your normal bone, the transition is ill defined. It is known as wide zone of transition, that is ill defined or wide zone of transition, and this tells you that it is an aggressive pathology. Aggressive pathology. Okay, this is clear. Now we'll read few of the important bone tumors in a spotter format, because this type of questions only come to you in your viva, not necessarily long questions. Again, PG point of view said detailed descriptions, detailed videos are in the app. You can check the app. This is more sort of a viva voice kind of thing. So number one is, how will I describe this X-ray? This is an X-ray of the distal end of femur, an AP view. I can see a lytic lesion in the distal femur involving the metaphysis and the diaphysis, a metadiaphysis lytic lesion in the distal end of femur. It has a narrow zone of transition. No significant periosteal reaction is noted. There is no cortical breach. Cortex is intact. Cortex is intact. So this is a benign tumor. This is a benign tumor. And in fact, what was this? This is actually a non-ossifying fibroma. non-ossifying fibroma. You have metadiaphysis location. It is lytic, no cortical breach. Now, similarly, here I see there is a lytic sclerotic lesion. Okay, some part is lytic, appearing black, some part is white. A lytic sclerotic lesion, predominantly a lytic lesion in the distal. What again? Metadiaphysis. This is meta, this is diaphysis. Metadiaphysis involving predominantly the cortex. It is eccentric in location. There is no cortical breach. So what is it? Is it benign or malignant? It is most likely a benign tumor. This was a case of focal cortical defect or an FCD. Now, in both of these scenarios, you can see that the growth plate is not fused. This is the growth plate here. The growth plate is not fused. So that means it is child. And in fact, focal cortical defects and non-ossifying fibromas, both of them occur in children. Right? Now let's see the next example. This is an AP X-ray of the knee, of the right knee. I can see a well-defined lytic lesion in the distal end of femur involving the lateral epicondyle, lateral condyle. It is reaching till the articular surface. There is no cortical breach. There is no cortical breach. There is no soft tissue. There is no aggressive periosteal reaction. Now, they'll ask you about the zone of transition. The zone of transition is narrow. Has a narrow zone of transition. Right? So is it a benign or a malignant? Tell me, is it a benign pathology or a malignant pathology? And what is the diagnosis? Yeah, it is indeed a benign pathology and it is a giant cell tumor. An important point here to note is that the growth plate is not seen. So it is fused. Growth plate is fused. That means it is an adult. Growth plate fused, it is an adult. And another pointer to say it is a giant cell tumor is its location is epimeta, epi and metaphysis. It is reaching till the articular surface. Reaching till the articular surface. Okay, so this is giant cell tumor. This is giant cell tumor. Now tell me this diagnosis. How will you label this? Just tell me if it's benign or malignant. I don't want you to answer this exact. Just benign or malignant. So this is a X-ray of AP X-ray of the ankle. I can see a sclerotic lesion, predominantly in the distal tibia, involving the meta and the diaphysis, metadiaphyseal lesion, predominantly involving the cortex, cortical lesion. Okay, so mostly it is a benign finding. Why? Because the zone of transition is narrow. There is no cortical breach. There is no cortical breach, no extraosseous soft tissue, no periosteal reaction. So this is a benign bone tumor. Okay, again a benign bone tumor. Now tell me here, what is the finding? There is this ill-defined lesion in the shaft of femur. So first of all, the location is diaphysis. It is lytic sclerotic. It is lytic sclerotic. Lytic sclerotic lesion in the shaft of femur in a skeletally immature patient. So it is a child because the growth plate is not fused. And I can see multilamellated periosteal reaction. Multilamellated periosteal reaction. This is what is known as onion skin. 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 Oni periosteal reaction, also known as multilamellated periosteal reaction. This is seen in Ewing's sarcoma. Ewing's sarcoma. Okay, now tell me the diagnosis. Is it a benign or a malignant lesion? So this is an AP X-ray of the knee. I can see a lytic sclerotic lesion. Okay, some part is bitten off, some part is ossified. So it is a lytic sclerotic lesion in the distal femur involving mainly the metaphysis and the diaphysis. Metadiaphyseal lesion है. There is cortical breach. Okay, cortex is broken here, and there is also this large soft tissue. Soft tissue mass is also seen. And regarding the zone of transition, the zone of transition is ill defined. Okay, this has a wide zone of transition. So is it a benign or a malignant? It is a malignant bone tumor, and in fact, this was an osteosarcoma. Osteosarcoma. Again, tell me, how will you describe this X-ray? This is a sclerotic lesion in the distal end of femur. Again, an ill-defined margins. नीचे के margin ढंग से नहीं दिख रहे. Extraosseous soft tissue. Extraosseous soft tissue, and this is what is a sunburst periosteal reaction. Okay, this was also a case of osteosarcoma. Okay, so जब भी wide zone of transition होगा या जब भी cortical breach होगी, extraosseous soft tissue होगा, it will always be malignant. Always be malignant. Now tell me, is it benign or malignant? Just benign or malignant? How will you describe it? What is the location? The location is in the upper end of the humerus. So this is an AP radiograph of the humerus and the glenohumeral joint. I can see a lytic sclerotic lesion, predominantly sclerotic, in the upper end of humerus, involving the epi or the meta, involving the metaphysis, with no cortical breach, no soft tissue. It is central in location and relatively well defined. This is a benign lesion. What is the diagnosis? This was an enchondroma. This was an enchondroma. Okay, so to summarize, any bone lesion, you first see whether it is sclerotic or lytic, and once you have narrowed it down to lytic or sclerotic, then see whether it is benign or malignant. Now there is this good mnemonic stamp C, which you all should remember. So whenever you're describing any bone lesion, so S is site, T is transition zone, A is age, M is matrix mineralization. So whether it is a sclerotic or lytic, P is periosteal reaction, and C is cortical breach. C is cortical breach. Right. So that is all about your bone tumor. So just to quickly revise, your lung lesions were consolidation, atelectasis, nodules, and masses. And as a homework, what I want you to read, I want you to read a small notebook known as Chest X-ray Made Easy. Chest X-ray made easy. It is a very thin, patli si book hai, Chest X-ray made easy. You can easily find it online. Try to read this notebook. Try to read this book. It will really help you improve your concepts of chest X-ray. Right? So if there are any questions, please mention them in the chat box. And for all the Farre of Final Pro of clinical subjects, you can download the Medit app and access the Farre from here. Okay, thank you. Okay, thank you, my student. So if there are no more questions, then we'll end up the session.